series for the Center for Transformative Nursing and Health Research. For any of you who don't know me, my name is Marcia Campbell-Yo. I'm a professor at the School of Nursing here at Dal and the acting director of the center this year. And I'm just so excited to see everyone joining us online. And just hello to everyone. Already I can see the broad representation here from the Nunavut Arctic College, here locally from the school, some of our students who are around the world, the three students who are going to present second in the room here with Lori. And so just before we begin, just to acknowledge that, this virtual class, I guess, is being held across many areas, which would be the unceded territory of the Mi'kmaq and or in whatever area you are in the Indigenous peoples from where you reside. And just wanted to take note of that. And today we have actually, I guess, 4 speakers. What's going to happen for these sessions? We usually have about 20-minute session and some time for discussion for the first session, and then followed by the second session the same. And sometimes it's an individual speaker, as it is in the case of our first speaker. And then there's going to be a panel in the case of our second round of speakers. And at that time, I'll ask Lori Graham to introduce our second speakers. But without further ado, I just want to have introduced Maddie. Gallant is one of our Rockstar PhD students who is going to talk to us today. And Maddie, maybe just take it away and tell us anything more about yourself and your background in perinatal nursing and about the topic that you're going to share with us today.
Sounds great. Thank you so much, Marcia, and thank you everyone for being here today and for taking the time to listen to my presentation. I'm very excited to share that. I'm going to try to share my screen now. Hopefully it will work. Are you able to see that, my slides?
Yes, Maddie, we can see that. You might be able to, I think, can you make them bigger? Maybe it isn't. Or it's okay. I think. Oh yeah, that works. Whatever you
did. Did it work?
It did.
Okay, perfect. Technology is not my strongest suit. So perfect. Yeah. So my name is Maddie Gallant. I am a BScN prepared registered nurse and a PhD in nursing student at Dalhousie University. My background comes from working in perinatal nursing, and I've worked kind of from the start of the continuum, so in conception all the way right through till postpartum nursing. I'm very excited today to share my passion for a project that I will be working on for my PhD and beyond, and kind of what I do in my clinical field as well. My co-supervisors are Dr. Christine Casti and Dr. Megan Ashton. And the title of my presentation today is going to be Implementation and Evaluation Strategies for the Eat, Sleep, Console model of care for neonates diagnosed with neonatal abstinence syndrome. And this is a presentation based on a scoping review protocol that we've just submitted for publication. Did that flip to the next slide?
Yes, yes, it did.
Okay, perfect.
Yes, it did, Maddie. You're doing great.
Perfect, thank you. So for today's presentation, I'd like to start by giving you an introduction into the project, kind of the purpose. We'll talk a little bit about the project background and the purpose for doing a scoping review. I'll then go into the methods that we will be using for our scoping review and then the plans for dissemination and what exactly this project is going to provide for my PhD, but also for our greater community as well. So as Marcia mentioned, I'd just like to take a moment to acknowledge that we are in Mi'kmaq, the traditional and or ancestral territory of the Mi'kmaq people. We are all treaty people. And I'd also like to take an opportunity to acknowledge the histories, contributions, and legacies of the African Nova Scotian people and communities who have been here for over 400 years. So just to provide kind of a little overview before I get into what my project is, for this particular project, I've used what's called an integrated knowledge translation approach. And essentially this approach to completing a research project is that knowledge users, patients, anyone that's going to be affected by the research are really key research team members throughout the entire duration of the project. So right from the very conception of this project, right through to dissemination, I have a diverse team of knowledge users that will be key in providing advisory, but also providing guidance on what type of questions, what type of dissemination methods will be used. And then the other thing is that it will ensure that I'm asking the most relevant and also responsive questions for my review so that I can make the greatest impact in the clinical practice. So as part of my team, I have 3 different knowledge users from IWK Health, a clinical nurse specialist, manager, excuse me, and also registered nurses that have been part of the implementation and evaluation of the ESC model, which we'll get into in a second to give some context. But their perspectives and point of views will be integral in ensuring that the questions I'm asking and also the findings from the study will be able to be seamlessly placed into practice. The excuse me, sorry. The other thing is that this project was founded on a priority identified concern across Nova Scotia. And so health system leaders, healthcare providers, but most importantly, patients have identified this area of research as being a priority. And we'll go into a little bit more depth why it's considered a priority, but it really speaks to the magnitude of the influence that these findings have potential to create. So I just wanted to highlight that. And then finally, the scoping review will provide a foundation for my larger program of research that I am proposing for my PhD study. It will provide me with an understanding, a comprehensive understanding of the different systematic processes that are used in implementation and evaluation of the ESC model. And this will just ensure that my project is founded on evidence-based questions and what's kind of already out there in the literature. So I just wanted to provide a little background about that. So neonatal absence syndrome or neonatal opioid withdrawal syndrome is a large growing population in Nova Scotia. So for those of you who may not be familiar, neonatal absence syndrome is an umbrella term that's used for infants that are born to mothers who are diagnosed with substance use disorder. So they've been exposed to a substance in utero, which then can lead to the diagnosis of neonatal absence syndrome once they're born, which is a range of different symptoms of withdrawal from that particular substance. More recently in the literature, they've been switching to more of an inclusive term specific for mothers who are on methadone or who are using opioids during pregnancy. And this term is neonatal opioid withdrawal syndrome. Right now, in the literature, we're going through that shift of moving from NAS to NOWS. I'll be using NAS throughout this presentation because a lot of the literature that I'm using is still using that terminology. But keeping in mind that the terminology is changing to be a more inclusive term, which is neonatal opioid withdrawal syndrome. And so in the last decade, NAS or NOWS has grown astronomically. And so from 2003 to 2014, although these stats are a little bit dated, they provide kind of an understanding that incidence rates went from 1.8 to 5.4 per thousand live births respectively, which is a huge increase for a very unique population. And these numbers are actually thought to be quite conservative because of the stigma and discrimination that mothers and pregnant persons with substance use disorder often face. So it's a very complex population. It requires extensive healthcare resources and support. For instance, typically these babies, before the introduction of the new model of care, which we'll talk about, would stay with us for an average of 15 days. So when comparing that to a baby who may not be diagnosed with neonatal absence syndrome, they may only stay in the hospital for 1 to 2 days max, depending on the type of birth that the mother experienced or the birthing parent experienced. So there's a really big shift from 1 day to 15 days, so almost 15 times that, where infants would be using all of those resources. The other thing is that infants that are diagnosed with NAS and are having extreme withdrawal symptoms are often managed with pharmacological management, which again prolongs the stay uses additional resources and requires additional support. So currently in practice, the care models that are being used are not evidence-based, and a lot of them are stemming from stigma and discrimination that continues to exist in this population. So that's leading to a lot of unintended and often negative healthcare outcomes for our mothers and for our babies. And it's been shown in the literature that mothers who experience poor prenatal care due to stigma, discrimination, fear of apprehension, those women typically have poorer health outcomes, including their infants who experience things such as preterm birth or a low birth weight. So all of those reasons really support the fact that we need to do something about this growing population for many reasons, but one of the biggest reasons is that it has such an impact on the health of mothers with substance use disorder and their infants with NAS. So because of all of these challenges and the new literature that's supporting this growing epidemic, there's been a prompt transition to address the growing needs through implementing a model of care, which is called the Eat, Sleep, Console model of care. So this model of care was developed by Grossman and colleagues in the US, and it was systematically developed based on the challenges that were used with the outdated model. So that outdated model is titled the FNAST, or the Finnegan's Neonatal Abstinence Scoring Tool. And so this tool had all of these different challenges, such as it being subjective, it having a lack of collaboration with the family. It was a 21 list symptoms-based evaluation that required us to disturb these poor babies that were going through a withdrawal and almost elicit, our disturbing or us disturbing them was actually causing some of these symptoms to occur. So after lots of time, quality improvement studies, going through those different steps in order to create a model, they developed the ESC model of care. And so this ESC model is a function-based assessment. It really empowers the collaboration amongst all team members, but especially of mothers and families within the care team. And they are the voice that we're listening to during the different huddles and the care that we provide, which is so important in caring for populations that are typically in the past have been stigmatized or experienced discrimination. And so although this is a really promising healthcare innovation, it's very exciting. It's adapting all of these things that we see in practice that are challenges. The implementation science literature tells us that often these large changes in our healthcare system aren't successful or aren't able to be sustained because there's no implementation or evaluation planning. And so healthcare innovations are more likely to succeed when a theory-informed, systematic approach is used to implementation and evaluation of the interventions, which brought me to a literature review to see, has this been explored, the implementation of ESC and the evaluation of this model in practice. And so, to my surprise, there was no systematic exploration into ensuring that this model could be successful and sustained in practice, which has brought me to our project, which is to complete a scoping review and really map out all of those different studies that have been done to evaluate or implement this model into practice and really gather a holistic and systematic understanding of how are we going to ensure that this model of care is being effectively integrated into the healthcare systems across Nova Scotia, or the healthcare facilities across Nova Scotia, to improve health for our mothers with substance use disorder and their infants. So the purpose, as I mentioned, of the scoping review is to map out all available evidence that is out there. And right now I'm going to go into a little bit more about how we're going to go about doing that. So the methods that we'll be using, I'll be following the Joanna Brings Institute methodology, as well as the ARC-C and O'Malley's scoping review framework. And both of these frameworks complement each other really nicely, and they're through a series of 5 different steps. We can systematically evaluate what literature is out there and synthesize it in order to have a better understanding and foundation moving forward with this project. So stage 1 is to identify what the research question is. And so our research question was determined through consultation with our research team, which, as I mentioned, included those key knowledge users. And so the question that we decided on was very basic but inclusive of how has the ESC model been implemented and evaluated in practice? And from that, we've broken it down into 4 kind of sub-objectives or sub-questions. First was what are the strategies that have been used to implement the ESC? 2 is what are the reported barriers and facilitators to the implementation? The third one looks more at the evaluation, specifically at the reach, effectiveness, adoption, implementation, and maintenance of the evaluation of the implementation of the ESC. And then finally, what are the reported outcome measures for this particular model? So that brings us to stage 2, which during stage 2 is to identify relevant studies that are going to be included. So that would be like our inclusion exclusion criteria. And JBI recommends a mnemonic that to outline your inclusion criteria, which is the participants, the concept, and the context. So for us, our participants were infants diagnosed with NAS or NOWS over 37 weeks. And the reason why we specifically focused in on that population was we wanted to eliminate as many confounding variables as we could. So for instance, infants that we may be born prematurely, they typically would have a longer length of stay, but perhaps that length of stay wasn't due to the fact that they were diagnosed with NAS. It was due to the fact that they were born at 32 weeks gestation. And our second, the concept, has kind of 3 subparts. So first of all, we wanted to find studies that talked about the ESC model. The thing with the ESC model is that often it's been implemented as part of a multimodal approach. And so instead of just being the ESC model and then kind of running with that, it was part of a intervention such as non-pharmacological management, increased collaboration, and then also increase space for the mother-baby dyad. So we said that we would include studies that talked with ESC, but also those other key foundational steps in case the article perhaps had those basic elements of the ESC, but didn't label it as ESC. The second subpart of that would be to look at implementation strategies, and then the third subpart would be to look at evaluation methods. So we wanted all of our articles to include the ESC or some form of it, an evaluation strategy, or an implementation strategy. And then finally, we would look for a context where the mother-baby dyad was preserved. And the reason for this is, again, there's additional considerations if you are implementing the ESC, let's say in a NICU, where moms and babies are separated, because that has a key impact on the outcomes that these babies may experience. So we tried to limit as much as we could the confounding variables. Again, with stage 2, the other part of it is to develop a comprehensive search strategy. So I spent lots of time going back and forth with our librarian scientists to determine how am I going to effectively map out all of the available evidence. And so I learned a lot about how much material is out there and how to make sure that I'm focused to not get overwhelmed with the amount of literature that's available. So we will be looking at published and unpublished materials. We use a 3-step search strategy to develop the proposed search. And then also we're using Godin's Gray literature methodology, which is just, again, a way to look through Gray literature to give us an idea of how to systematically evaluate and to map out that evidence. Stage 3 is just essentially the study selection. And so we will be using 2 independent reviewers throughout the entire duration of this step. There'll be a couple of different steps in selecting the titles that will be used for full review. But for instance, the first step would be to have 2 reviewers screen titles and abstracts. If those studies made the inclusion criteria, then they'd go into a full text review. If those met all those inclusion criteria, then they would then go into the final stage of synthesis. And we'll also be using the Prisma extension to map that out. Stage 4, and so this is for charting the data. So this is how we're going to really bring out all of that information and synthesize that information from all of the different studies. So the first thing we'll be doing is just general characteristics of the article. The second part is going to be coding the data, and we decided to do a directed content analysis for our articles, and we picked based on our objectives, which type of framework we would use to guide our analysis. So just being mindful of the time, I'm just going to speak to two of those. So the first one that we'll be doing is looking at the barriers and facilitators of the implementation strategies that were used. And so we decided to use the theoretical domains framework as well as the COMB, so the capability, opportunity, motivation framework. And the reason why we picked these is because they have been used to evaluate or to understand better the healthcare associated implementation of healthcare innovations in practice. And so it will provide us with a comprehensive internal as well as external overview of the different studies and of the barriers and facilitators found in those studies. Another area that I just wanted to highlight is the fact that we'll be using for 1.3, looking at evaluation strategies, we'll be using the RE-AIM framework. So again, as I mentioned, that reach, effectiveness, adoption, implementation, and maintenance. And it has been shown in the literature to be really great at looking systematically at the interconnected factors on multiple levels. So the individual, the organization, as well as the community levels. And so that will give us a better idea of kind of how those evaluation strategies evaluated those specific reach, effectiveness, et cetera. And then finally, stage 5, we will collate and summarize our results. So it will be based on our target population on how we will be collating this. But essentially what we'll do is have detailed tables based on our objectives, a diagram to support visually the representation of our findings, and then also narrative descriptions of our qualitative and our quantitative data. So finally, that brings me to, after doing all of this work, what kind of impact are we going to have on our community or on our healthcare system? So we really feel that this information is going to be helpful and has the potential to be used to support future implementation and evaluation of the ESC in practice. Findings are going to be disseminating these findings will be based on the target audience. So for instance, in terms of the implementation science literature of, what works best in practice or what has been seen to work best in practice, we'll prepare a manuscript of the full review for peer-reviewed journal publication. But on the other end, for the healthcare providers or knowledge users right on in the healthcare system, we'll do local meetings, educational sessions to really help support and have a better understanding of how do we effectively implement and evaluate this model in practice. Second, as I mentioned, it's going to provide that foundational knowledge for my PhD to design the methods for completing a systematic process evaluation. And then, and I've already spoke to my last point on this slide. So thank you so much, everyone, for taking the time to listen to our proposed scoping review protocol. I can provide references available on request. Our manuscript has been submitted and our authors are listed here. It's also available in preprint format on DALSpace if you wanted to take a read. Thank you so much.
Great. Thank you so much, Maddie. We have 5 minutes, so if anyone has questions for Maddie, please feel free to ask her. Well, when people are asking, you maybe just can raise your hand and I'll just ask you to speak. But while they're thinking about the question, Maddie, I just have one about the RE-AIM. In that, does maintenance, does it align with sustainability? Is that the same concept?
Yeah, exactly. How are we going to ensure that this model is going to be able to sustain throughout those barriers and facilitators? So maintenance really gets at that, what elements do we need to introduce to ensure that the model is going to continue in practice, such as, yearly reviews or bi-yearly education sessions, that sort of thing, to really help. But yes, exactly. That's where it kind of fits in there.
So it's along the same idea. Because if you think about implementation strategies, and sort of often you hear the word sustainability, but you don't necessarily hear the word maintenance. So it's just interesting to me that I think. Any other questions or comments to Maddie? It's a great talk. Okay, I'll have one more. I'll ask
That's
one
good.
more too. So it's about the re-aim, because it's not, again, not all the terminology. So intervention fidelity, or whether or not people actually do the intervention,
Mhm.
is that where you would put, instead of fidelity, would that fall under adoption? Or
Yeah,
because they are very subtle, because adoption, you could adopt it as a practice, but it doesn't mean everyone doesn't actually do it.
right.
So
No,
wondering how you tease those out.
so really great question. And I feel like I'm head deep in information about REAM and learning about it. But that's actually found in the reach. So how many it's kind of it's found in the reach, but also in the adoption, and they work kind of in parallel together. But reach is how many people are were exposed to it, how many people use it, the more that I'm learning about the REAM framework, the more I'm realizing that each individual assessment isn't done in isolation, and that each one kind of supports the other one. And they also work together in order to have this comprehensive evaluation. So to answer your question, it's kind of found in both that reach and the adoption, which is kind of where I'm having some challenges on deciding, how exactly am I going to evaluate this in terms of the questions for my PhD? Is it a quantitative approach? Is it a qualitative approach? Is it both? So yeah, hopefully that answered your question, Marisha.
Yeah, it's great. Great. I see Megan. There you go,
I have to
Megan.
say something.
You want to ask your question?
I know I only got 2 minutes. Anyways, I just want to say I'm so excited about Maddie's research and just to really get the ball rolling with the scoping review. It's a just wonderful example just to see what's out there. And doesn't seem like there's a whole lot. So yeah, anyways, just wanted to say I love your presentation and yeah, it's a really unique area. So great job.
Thanks, Megan.
And just to say, there's a few comments in the chat about what a great presentation you did, if you want to read.
Oh, thank you, everyone. Appreciate that.
Fabulous, fabulous. Thank you so much, Maddie. And Lori, I think you are in the room with our next presenters. Would you
I
like
am.
to introduce them?
Yes, it's with
Excellent.
great pleasure. Thank you so much. We really appreciate that, Marisha, and wonderful presentation, Maddie. Such valuable work that you're doing. It certainly is going to be very informative for all of us involved in the care of that population. So looking forward to seeing what's to come for sure. So it is with absolutely immense pleasure that I am going to introduce three outstanding BScN students in our program. So we have with us in the room Jess Ambrose, who's currently in semester 4, Eva, 7th. I'm so sorry. I'm so sorry. You were in semester 4 a year ago. Eva Purcell-MacIntyre, also in semester 4 and 7. Sorry, I'm very tired today. So sorry. You don't have to worry about messing up. I'm just messing up your intro. And Jonah Pridham. And Jonah is in semester 6. Yes. All right. And without further ado, I'm going to let the team take over. Thank you so much.
Want to share a PowerPoint first?
Yeah.
We're just going to try to share a PowerPoint. We're just trying to make it a little bit bigger on our screen right now.
Hey, it looks great on our screens. But it's small on yours.
So can everyone see our slides?
Yes.
Yes?
They said they can't see it. Okay, so I'm seeing them. Okay.
You're seeing them?
Okay.
Oh,
Is everybody else able to
Er,
see?
Maybe.
Okay. Hey.
Hmm?
Great. Okay,
Oh,
great.
yes.
Perfect. Okay. Hi. I'm Eva. I'm semester 7, as Lori said, nursing student. So we're here to talk about interprofessional collaboration, and we're going to talk about our pediatric injection training program in Nova Scotia and what we're doing with it. Okay. So meet the team. So we'll
I don't
get.
think it changed on the, did it change for you?
Oh,
Okay,
I'm
sorry about that,
Oh,
everyone.
sorry. The technology.
just if you put your
I
cursor
think we might have to.
down where it
read
says
up.
1 of 10.
Okay, yeah, that's fine. Sorry.
Yeah.
Oh yeah, we can post
Try
the
that.
presentation slides.
Anyways,
Oh,
sorry. So
you got
meet
it
the
now.
team. So
Great.
we'll talk a little bit more about how the collaboration comes in between the team members. But we have a lovely team made up of nurse practitioner students, pharmacists, pharmacy students, registered nurses, and nursing students. So lots of interprofessional collaboration going on here. So what is the project? So the pediatric injection training program is a 2-part project. So the first part is an online aspect. It's providing teaching, there's videos, there's PowerPoints, and then there's a final quiz that the pharmacists participate in to just ensure that they understood key concepts. And then the second half of the project is training sessions that's focused on injection technique and specific best practice techniques that are tailored to the pediatric population, specifically looking at 6 months of age to 2 years of age. And I would like to note that Nova Scotia is the first province to authorize pharmacists in administering vaccines to children between 6 months and 2 years of age, given the appropriate training, which is fantastic. So I'm going to go over some of the key concepts within the training here. So essentially the education sessions focus specifically on the administration of intramuscular injection. And we specifically focus on 4 main components of that, starting with pain control. So this would address things such as topical anesthetics. We have something called the Buzzy Bee, which is a tool that's kind of used to play on the gate control theory for pain. We talk about oral sucrose for infants under 12 months of age, and also the importance of breastfeeding and how that can really help support parents and the infant during the process of receiving an injection. We also look at the distraction techniques that can be used that are age appropriate. So breastfeeding would fall in this as well. We look at digital devices sometimes being a really good way to distract children, games, books, bubbles, all those things that kind of shift their mindset from being really focused on the injection and being more kind of comfortable in the situation that they're in. The next thing that we could look at is positioning. So this really varies based on the age of the child, the comfort level of the parent and the child, and even the comfort of the care provider or the administrator. So we really look at how different ways of positioning can ensure not only comfort, but safety for the patient and the person administering the injection. And finally, we look at landmarking. So we do site selection based on the age, the size of the child, and we kind of help pharmacists use their clinical judgment in that process. And using anatomical guides and whatnot, we focus on how to landmark for the vastus lateralis and the deltoid muscle. So those are the main things that we focus on the days that we actually are training in person. So as we mentioned before, this is definitely a very collaborative project. We've worked with a really amazing, diverse team, and we wanted to look at the IPE competencies that we outlined when doing this project. So as far as team functioning goes, it's definitely been a lot of diverse professionals and students. So it's really nice to have the perspective from both lenses, and it really bridges the knowledge between academics and practice, and again, scopes of practice. As far as collaborative leadership goes, we've definitely noticed that every team member has been really excellent at bringing their skills into the program and being able to implement what they know and their experiences at different stages of the program. And it also allowed for a lot of knowledge sharing, because as students in the BScN program, we're learning a different set of skills than what practicing pharmacists and pharmacy students are implementing. So it was really nice to collaborate at that level. We also had a lot of role clarification. This was super important because everyone that was on the project had different scopes of practice. Some have multiple scopes of practice. So identifying those scopes and allowing those people to really shine during, question periods that not the whole crew may be super clear on. It was nice that we all knew there was someone that we could turn to. And as far as conflict resolution goes, it was always a very safe, supportive environment, even from the get-go, when we were getting to know each other as a team. And it made for a great space of support and learning. None of us felt at any given time, I don't think, that there was ever a reason to not ask a question or repeat a question. And so all together with this team, we really made the project what it is now. And we were able to reflect and learn from each other a lot.
So our role as a nursing student, again, lots of collaboration went into this and is still ongoing. It's fantastic. So from our perspective, we helped create the video. We were part of teaching how to landmark in the videos. And we also collaborated with the rest of the team on creating questions that the pharmacist could answer at the end in the final test, which was super important.
And we also took a really interesting role as students who are currently in the BScN program, because we are in classes every day and learning every day. So we were able to bring the knowledge that we have from our own program and how we learn best and implement that into the training. So an example of this was originally at the end of the training days, we would have what we called a testing session. And essentially this was a space for the pharmacists to come in and demonstrate their knowledge through kind of like a simulated learning experience. So we had a simulated patient as well as a person that was assessing the pharmacist or pharmacy technician. And we found that a lot of times the word test brings a lot of people, a lot of nerves and a lot of anxiety surrounding that. So because we're doing this every day, we kind of informed the team that coaching session might be a better term to use so that it's more of a learning opportunity as opposed to a test of knowledge. And I think this was really interesting because even though some of these professionals haven't been in school for some time, they definitely feel the anxiety around the word test. And that's something that we all experience as well. We did a lot of preparation for the role as well. So we did a lot of learning around adult education. We were provided amazing resources to be able to really understand the meaning of interprofessional collaboration and the principles of adult learning. So combining that knowledge with what we already had, it was a really great way to bring the program all together and make it a really positive environment for everyone.
So student as teacher, our perspective. So in this program, we were given the unique opportunity to teach practicing pharmacists as Bachelor of Science in Nursing students. And the figure on the right depicts how our role as a student informed our role as a teacher. For example, I just previously mentioned how we switch the term from test sessions to coaching sessions, because a lot of the pharmacists mentioned how this brought up test anxiety for them, because when people hear test sessions, they think of OSCEs or a clinical skills test. And sorry about that. And we wanted to create a non-stressful environment. And so we suggested this to the team and implemented it. And our role as a teacher also informed us as students. For example, in this project, we used the see one, do one, and teach one approach to mastering a competency. And this is used in medical school. First, we were able to see the competencies being done, and next, we were able to demonstrate these competencies during the sessions with the pharmacist. And last, we were given the unique opportunity to teach the practicing professionals as students. And we currently feel very well versed in all of the competencies that we went over in the program. And the research shows that this can be attributed to the model that we use to learn the competencies. And next, the equalized power differential. So usually as students, we find ourselves in a relationship with professionals where they have the power and authority. But our solidified role and knowledge base made this power differential to feel as if it disappeared with the pharmacists that we were teaching. While it is negligible to say that this power differential didn't exist, the conversations and discussions that we had were based more on equal footing. And this was beneficial in many ways to help us build rapport and to understand one another. And one of the arrows says mutual benefits. And when presenting, we would often hear similar comments from pharmacists about things that did and didn't work in their practice, and also about the challenges that they face on a daily basis. The diminished power differential allowed us to build rapport faster and to talk about these issues while they were waiting for their coaching session. And understanding these concerns allowed us to comprehend the struggles of pharmacists in a new light, which will benefit us in the future when working with the interprofessional team. The idea here is that if we can begin to see the world from their point of views, then we will become more open-minded to other people's ideas when collaborating. And this addresses a common barrier to interprofessional collaboration, which is differing professional perspectives. And according to the evidence, to bridge this gap, professionals must get familiar with the other professions' knowledge base and values, which is what we were able to do in this program. And what we have learned. Firstly, we gained a stronger understanding of the value in collaboration with other professionals. This project started out with nursing students, pharmacists, pharmacy student, and nurse practitioners, which allowed us to work with a diverse group of people towards a first of its kind project here in Canada. In the beginning, we would have meetings after each session to assess what went well, what didn't, and what we could change to make improvements. In nursing, this is referred to as the evaluation step in the nursing process, but in the project, this was known as quality control. This quality control involved everybody, including the feedback from pharmacists. This demonstrated the true idea of collaboration, which is to involve everybody. And we also solidified concepts we learned in the nursing program. As discussed before, we were also given the ability to strengthen concepts that we learned in the nursing program. This benefited us in many ways when going into clinical practice, especially when giving pediatric injections. When giving my first injection, I used all the techniques that we use in this program, and this resulted in a great experience for me and the patient. They did not cry at all, and they were distracted the whole time. And this can be attributed to the positioning of the patient, the distractions used, and the impact of breastfeeding on pain mitigation. And we also learned how important it is to ask questions and support colleagues when learning. All of us came to the project with diverse experiences and expertise, so asking questions and sharing experiences as a team made us a very strong group. No one knows everything, and we learned the importance of promoting a non-judgmental and safe environment. We all felt comfortable to ask questions when we didn't know the answer. And in healthcare, this is especially important because clarifying concepts can help to improve the quality of care that we deliver. It is one thing to read about this in a textbook and a whole other thing to experience this psychological safety firsthand. And we were lucky to be able to experience that.
So that's our presentation.
Thank you so much for
Thank you.
Listen.
And here are the references that we used. Here we go.
Quite a few.
Yeah. And we would be happy to post the slides afterwards if anyone would want to. We can definitely make that happen. And if anyone has any questions,
Great. That was just a fantastic presentation. So interesting and so inspiring
you're
for you
welcome.
as undergraduate
we
students.
can't hear anyone. I'm just,
So
I'm gonna try to unplug this, see if it helps.
Are we muted?
is that better? Can you hear now?
Oh, there we go. Oh,
Are you hearing now?
yeah, we
Yeah,
can hear you
yeah,
now.
we
Sorry
are.
about that.
Oh, okay. So I will just reiterate a fabulous presentation. So inspiring. Love your initiative and so wonderful work as undergraduate students. And your intercollaborative approach and presentation was fantastic. And of course, someone who's very interested in pain and preventing pain, even more excited about it. So, and if any of you want to do graduate work, look me up.
Thank you so much.
Absolutely. So Megan, you have a question.
Hi, probably more of a comment, but fabulous presentation. Thank you so much. And yeah, you can just feel the energy and really exciting work. So important. I wanted to say, I remember it must have been about 15 years ago in the School of Nursing, and pharmacists were not giving injections. And I know many of our faculty had that conversation between the School of Nursing and pharmacy. So at that point, we were looking at that co-learning and, there's a little bit of turf wars and who should be doing it and scope of practice. I just remember those conversations. So you've just presented it so beautifully, and just the idea about collaboration and where we've come from and where we're at now. So just love that. And even the word collaboration, how does that happen? So the way you presented it with all of the details and some of that meaning, excellent. The couple of words that stood out for me, of course, were power. I do feminist post-structuralism. So just being able to talk about that and the importance of respect, that came through really, really clearly, and sort of that psychological safety and non-judgmental. So hearing all of that. So I just want to ask the three of you, just your experience of it all. Do you think it was really positive, or were there any challenges? I don't know. I'm just feeling a lot of positive that came through your presentation.
I'll start off.
Yeah.
Oh my goodness. Well, when Lori first told us about this project, I was beyond excited and because I had never really thought about research until I started this project, and I've actually become so much more interested, engaged, and curious, which is fantastic. And I think we had such an amazing team. It made everything so much better, and I'm very thankful to have been brought in on this project. And I think my favorite part was probably learn how to teach other people, something that I found that I wasn't very strong in. And I feel like I have been able to grow and learn just by watching how Lori and all the other amazing teachers are out there and implementing that, teaching other people. And my confidence has grown with this project. So I'm very thankful, and I'm very thankful for the amazing team that we have.
I think I'll reiterate what Eva said. This project was amazing. When Lori emailed me about, hey, do you want to get involved? I was ecstatic, and just getting to go there and work with everyone and just be a team and be a great team at that was just amazing. And yeah, I've learned so much from the project. It really helped me solidify concepts, and it really helped me to learn how to teach people, because I could see myself using techniques that some amazing professors in the School of Nursing use, and just using that, and then it worked. And yeah.
I would say as well, I can't say enough how big of a privilege it feels to be part of this so early in our career. It's been really special to have this perspective, because I think you can carry it anywhere, any area of nursing, any area of healthcare in general. Collaboration is such a big component of it. And I think feeling comfortable for us to ask questions and clarify concepts and learn from each other has been so valuable. And it's something that we're all going to carry with us through the rest of our professional careers. And I think it's really started an interest in
It
in
has.
furthering our education and
Absolutely.
that sort of thing. I don't want to speak for you guys, but
Oh,
I think
It does. It has. No, it's been great.
Wonderful.
Thank
Is there
you.
any-
Can't wait to see what you do next.
thanks.
Thank you.
And there's some great comments in the chat. Is there any other questions? I don't see anyone. So some of the things in the chat. Shelley Corbett says, great presentation, an exemplar model of IP collaboration. Can't wait to read all about it in a journal publication. The Yarmouth campus was thrilled to host part of this team for a weekend to work with local pharmacists. Great. And then I don't know if the Brick NS guest, if you want to make you had a lovely comment here. Do you want to speak to that verbally, or should I just read your comment?
That's okay.
So basically, it's just a comment. From listening to your presentation, it sounds like there was a lot of psychological learning techniques used to reduce testing anxiety and training for the professionals. For example, as students, you'd mentioned others learning while solidifying your knowledge, a process often referred to as mentoring your peers or collaborative learning. In addition, you discussed experiential learning technique applied in medical school, which can be comparative to John Dewey's learning by doing. And this also helps reduce debilitating anxiety associated with testing. So just really acknowledging how much you've used past literature and other people's examples to learn to train and work with people and teach. So just what you alluded to earlier. So great comments.
Thank you so much. That means a lot. And thank you so much, Sydney. We'll definitely be reaching out to you with lots of questions. That's great. Thank you.
So any other? Oh yes, and absolutely. I will also say, if you have any interest in pain, any interest in graduate school, please feel free, or even if you're not, be happy to even to reach out through the center and with whatever specific interests. And we know lots of the researchers, and we can help facilitate that, or reach out to anyone, I'm sure, of us here online. We're always looking for the best and brightest, and I think you are exemplars for that. So
Thank you.
Well, thank you so much.
any other questions or comments before we? Yeah, everybody's right. If you like pain, if you like IPE, contact me.
This is great. No, this is
This is
fantastic.
wonderful.
Yeah. Amazing opportunity. Thank you so much.
Yeah, absolutely great. So if there's no more questions, I think maybe we'll just take a couple of minutes to again thank you guys so much. You're such an inspiration for all of us to see great students come into through our program and to our profession. And
Thank you so much.
and then we'll ask maybe Julie if you'd like to share your slide about who's next. So just a reminder that we have our center sessions on a regular basis every 2 weeks this time, and please keep a look for the posters and advertisements. Please join us. We have a great turnout today. And Julie, are you able to share?
Yes, can I ask the students to stop sharing so I can share?
Yes.
That'd be great. I think that will work.
There we go. And thank you everyone for coming to watch our presentation. We all really appreciate it.
Great. So
Great.
if I share my screen and I get rid of that, can you see this poster?
Yes, go ahead, Julie.
Can you see the poster on the screen?
Yes, we can.
Okay, so the next, in 2 weeks' time, we have the library people who are doing a joint presentation on their support for data management, author rights, open access, and more. So it's Louise Gillis and Melissa Rothfuss.
And so this will be an incredibly informative session, I think, for all of us. Always so much to learn from our the communications and the librarians, and so please join us October 19th, 12 to 1, and we'll be looking forward to having some more very interesting information and discussion. And again, anyone who would like to become a member of the center, please feel free to just go on the center website on the School of Nursing. There's a form, very easy. Love you to become a member of the center. And also, there's a few spots left. And so if you have any interest at all in presenting one of these sessions, please feel free to reach out to Julie Berry or through the center email and just let us know, and we'll be really try to find a spot for you. We'll be doing this right through to the end of the school year in the spring. So without further ado then, everybody have a fantastic day. Thanks again to our presenter, Maddie, for such an interesting overview of her scoping protocol with respect to Eat, Sleep, and Console for infants with opiate withdrawal syndrome. Really good luck with your work, Maddie. Very interesting. And to the 3 students, fantastic exemplar of IP collaboration, and really students taking such important role in furthering our profession. So bye, everybody. Take good care.